Good evening and welcome to the Rhode Island State House. This is the House Committee on Health and Human Services. Today is Monday, March 22nd, 2021. We are in the House Lounge. We have members here with us physically, and we also have members joining us live via Webex. Clerk, are you ready to take the roll, please?
Yes. Chairman Casey.
Here.
First Vice Chair McLaughlin. Second Vice Chair Donovan.
Here.
Representative Ackerman.
Here.
Representative Azanaro.
Present.
Representative Bennett.
Present.
Representative Beer. Representative Kassar. Representative Fogerty.
Present.
Representative Geraldo.
Present.
Representative Handy. Representative Morgan. Representative Potter.
Present.
Representative Roberts.
Present.
Representative Speakman.
Present.
Okay, Chairman, we have a quorum.
Thank you for that. I will entertain a motion to hold all the bills on today's calendar for further study. So moved by Representative Ackerman. Can I have a second?
Second.
Second by Representative Josh Geraldo. Can I have a roll call vote, please?
Chairman Casey.
Yes.
Representative McLaughlin. Second Vice Chair Donovan.
Yes.
Representative Ackerman.
Yes.
Representative Azanaro.
Yes.
Representative Bennett. Representative Bennett, can you hear me?
Yes.
Okay. Representative Beer. Representative Kassar. Representative Fogerty. Representative Fogerty? We can't hear you.
Yes.
Okay, thank you. Representative Geraldo?
Yes.
Representative Handy? Representative Morgan? Representative Potter?
Yes.
Yes, Morgan's here.
Okay, thank you. Representative Roberts?
Yes.
Okay, Representative Speakman?
Yes.
Okay, Chairman, we're all set.
Thank you, everybody. We have a quorum. First, we are going to do Representative Lombardi's bill. It's House Bill 5847 relating to state affairs and government for the Commission on Standards and Training. Representative Lombardi, you have the floor. Go ahead, please. Representative Lombardi, you're muted. Could you please unmute?
Sorry, Mr. Chairman, members of the committee.
Thank you.
So, thank you for endeavoring to hear this matter. This act would require mandatory training standards for police officers and trainees in identifying, responding, and handling all incidents involving any person with a developmental disability. As some of you recall, back in West Warwick at the liquor store there, the gentleman there was the officers were asking him to respond. He was not responding, and unfortunately, it was met for his untimely death. Someone called me today with a situation where someone took a massive stroke. They were leaving a convenience store with their vehicle. They were pulled over. Allegedly, there was a broken light or something to that effect, and the person was not. They had taken a massive stroke, and they were having a little difficulty understanding what the police officer was asking about. They asked him to exit the vehicle. He stumbled coming out of the vehicle, and with that, it ended up being a DUI and a refusal, and the guy was just not understanding. And look, police officers have a lot to do as it is, but it's something that we really need to identify these specific situations, and you know, in many cases, it will help to take out some of the air, some of the situations that we've been reading about. Look, in every aspect of life, whether you're a teacher, a priest, a lawyer, whatever you may be, you're much more than what you just are, what your title says. In some instances, you're going to be a doctor, a psychologist, psychiatrist, and so on and so forth. I was in education, and I know I was in, I coached. There's a whole bunch I taught. And, you're not just what you are, you're more than that. And certainly those of you who have children know what that's all about. I've never had children. So with that, Mr. Chairman, members of the committee, I will endeavor to, I think it'll make a better police force for, all the 39 cities and towns in the state of Rhode Island. With that, I'll try and answer any questions. At least I will attempt to. Thank you.
Thank you, Representative Lombardi. Are there questions from the committee? Representative Morgan, go ahead.
Yeah, Chairman, West Warwick was one of the towns that had just a tragic incident with somebody who had developmental disabilities. And so I really do believe police officers, they didn't know what they were facing, but they need training so that when somebody is having an episode of whatever type, whether it be with a disability or, like you said, a physical issue, they know how to respond appropriately. This man died and didn't have to.
You're 100% representative. If I may, Mr. Chairman, that's exactly one of the incidents I was referring to. And of course, we've seen it across the country. In New York City, certainly, police officer. Well, we've seen it. It's enough to be said. I mean, I don't think. To me, it's a res ipsa loquitur. It speaks for itself. That's it. Thank you.
Thank you. Are there any other questions from the committee at this time? Okay.
Thank you, Mr. Chairman and members of the committee. I appreciate your indulgence on this.
Thank you, Representative Lombardi. Before we go to our first caller, Representative Bia is here. He would like to have his presence noted and his vote recorded to hold all the bills on the calendar for further study. Is that correct, Representative Bia? Thank you.
Thank you, Chair.
Okay, we're going to take our first witness. Hello, Mr. Marshall.
Hello, Chairman. How are you today?
I'm doing fine, sir. You're with the Health and Human Services Committee on House Bill 5847. You have the floor. Please go right ahead.
Thank you. Thank you for the opportunity to speak on this bill on behalf of the Rhode Island Developmental Disabilities Council. We did submit written testimony that goes into detail. I'll just give you some quick highlights. We do feel that there is a real need for police officers to receive training in this area. We also feel that there's a need beyond that to have training available for detectives to deal with the situation when a person with a disability is either the victim, a witness, or the perpetrator of a crime. That is another shortfall that is there that has led to a lot of issues and that were identified in the commission that the legislature ran a few years ago to look at these issues. The issue with the bill before you that we're concerned about is that there is in Section 2 of the bill, there is a change to the language of the definition of developmental disabilities that the state uses, the Department of Behavioral Health, Disabilities, and Hospitals, that changes the actual definition to a much broader definition, which would cause some real problems if it was implemented as written, because you would have a drastic increase in the percentage, the numbers of people that would be eligible for services at BUDA. To address all of these issues, the council recommends that the committee give serious look at moving forward a bill which is in the Judiciary Committee and was heard on March 9th in the Judiciary Committee, which addresses all of the issues that this bill does and also addresses the need for training with detectives and doesn't make the change to the definition of developmental disabilities. So with that, I'll be happy to answer any questions.
Thank you, Mr. Marshall. Are there any questions for our witness from the committee? Okay, hearing none. Are there any other comments from the committee before we close the hearing? This is our only witness. Okay, thank you, Mr. Marshall. We appreciate your testimony.
Thanks.
Okay, with
Thank
that,
you.
with that, I will close House Bill 5847. We're going to move on next to Representative Potter's bill. Representative Potter's bill is on page 2 of the agenda. It is House Bill 6014. An act relating to health and safety regarding the Office of State Medical Examiners. Representative Potter, you going to do from your chair?
Sure. Thank you, Mr. Chairman.
Thank you.
Appreciate
Go right
that.
ahead.
So, very simple piece of legislation. This was originally from a bill that Chairman Bennett had put in back in 2018. This would simply remove the sunset provision on the requirement that the Office of State Medical Examiners be responsible for a multidisciplinary team review on drug-related overdose deaths and work collaboratively together to minimize that. And the best way to address the current crisis that we see. I did speak to the Department of Health about this. This is a bill that came from them, and I spoke to the ACLU, who had some concerns that carried over from the initial passing of the bill back in 2018. So I'd like to work with you, Mr. Chairman, on potentially amending that. I do have a conversation planned with people from the Department of Health and some members of the committee and the ACLU. So hopefully we can try to tighten this up a little bit. But obviously, very very simple and very important work to remove that sunset provision at the very least.
Chairman, we do have a letter from the Department of Health. Was it the Department of Health that you mentioned?
Yes.
We do have a letter.
Yes. So are there any questions for Representative Potter before we get to testimony? Okay. So prior to the verbal testimony, I just want to let you know we have received 4 letters of support, one from the Rhode Island Medical Society, one from Jordan Goyette, one from the ACLU of Rhode Island, and also the Rhode Island Department of Health, Dr. Alexander Scott. These are all in support of the bill, and we're going to move to our first witness virtually by phone. Go right ahead. Who is it? Hello, Neil.
Hi, Chairman. Can you hear me okay?
Yes, I can hear you okay. You're here on House Bill 6014. You have the floor and our attention. Please go right ahead.
Excellent. Thank you, Chairman, and thank you, members of the committee. My name is Neil Heighton from the Rhode Island Department of Health, and on behalf of the Director and our Office of State Medical Examiners and our Overdose Prevention Program, we'd like to thank Representative Potter for sponsoring this bill on our behalf. The bill before you today would remove the sunset provision in current law establishing our overdose fatality review team. In 2018, the General Assembly passed the initial law that created this team and tasked them with conducting comprehensive system reviews of overdose fatalities, with the goal of identifying overdose risk factors to improve local prevention planning, identifying missed opportunities for prevention and intervention, making recommendations to laws, policies, programs to prevent future deaths, and increase interagency communication, collaboration, trust, and buy-in around overdose prevention. The Overdose Fatality Review Team meets on a quarterly basis and includes stakeholders from the prescribing community, first responders, treatment providers, the recovery community, addiction specialists, our Office of State Medical Examiners, and prevention coalitions. After each meeting, a data brief, key findings are published and shared with stakeholders, including the Governor's Task Force on Overdose Prevention and Intervention and its working groups. Stakeholders then work to identify ways to incorporate the findings into their work, and over the past few years have enacted policies to strategically distribute naloxone to groups and geographic areas most at risk during specific times, target certified peer recovery specialists and community health workers to engage individuals most at risk and connect them to help and sustain treatment and recovery and connect to basic needs, support and develop policies and regulations that improve safe and responsible prescribing of opioids, and tailor and adapt harm reduction messaging and media to decrease overdose risk among the at-risk populations. Because the focus of these reviews is on public health systems and prevention and intervention, and not legal action against the decedent or witness, it's important to retain the language currently in statute that the work product of this team not be made available for use in court proceedings. The work product of this team is not intended to be used to make arrests or prosecute specific individuals, and the language included in current statutes ensures these goals are met. So with that, we've provided the committee, along with our written testimony, a copy of the team's most recent report to the legislature, and we'd be happy to work with our sponsor and the committee to provide any additional information that will allow the team to continue to do this work. So thank you. I'm happy to answer any questions.
Thank you, Neil, for your testimony. I appreciate that. Are there any questions from the committee at this time? Okay, hearing none, we're going to move on. Thank you very much, Neil. We're going to move to our next witness.
Thank you, Chairman.
Hello, Hannah Stern.
Hi.
Hi, this is Chairman Casey. You're here on House Bill 6014. You have our attention. Please go right ahead.
Great. Thank you. Thank you so much, Chairman and members of the committee, for your time this evening. My name is Hannah Stern. I'm testifying on behalf of the ACLU of Rhode Island. When this legislation was initially introduced in 2018, our organization expressed concerns about really the significant presence of law enforcement and corrections personnel who sit on this team. We remain extremely concerned about that aspect of this bill. The opioid crisis really is a public health issue, so we think that it should not be addressed through the perspective of law enforcement. And while we would urge limiting law enforcement personnel on this team, if there are strong feelings about the personnel who sit on this team, at the very least, we really do think it's imperative that an amendment be added to this bill, which would strengthen confidentiality safeguards. So we drafted an amendment. It's detailed in our written testimony, but just briefly what it would do is ensure that any evidence or information gathered during the team's review would be inadmissible in any court aside from the non-identifiable information which is otherwise available under APRA. So unless at the very least this amendment is made, we urge rejection of this legislation. Thank you very much for your time. I'd be happy to take any questions.
Thank you, Ms. Stern. Are there any questions for our witness from the committee? Okay, seeing none, we will go ahead and move on. Thank you, Representative Potter, for your testimony and on your bill. We're going to close House Bill 6014. Next, we're going to move to Representative Kassarian. Whip Kassarian's bill is number 6018. That is on page 3 of your agenda. Representative Kassarian, you have the floor. Go right ahead, please.
Hi, Chairman. Hi, committee members. Thank you all for having me tonight. House Bill 6018 is a bill I was asked to put in to respond to some issues that a lot of our healthcare workers have been facing at the hospitals. We've unfortunately seen an uptick in violent acts happening. So they wanted to come up with a way to tell the hospital workers to report these incidents and then for the hospitals to follow when these incidents happen. So this bill is going to do 4 things. It has a notification process telling people how to report when there's an incident. It has a section in it that would prohibit any type of retaliation happening to a member that reports an incident. It would add preventative measures. So it would have some people, they would have a council that would make sure that there's plenty of safety measures in place at the hospital. It would also have some educational classes teaching about about ways to care for each other at work and make sure people aren't getting hurt. And then last, and I think most importantly, it would make the hospital responsible for maintaining the records of incidents being reported and what happened next. So that's what the bill does. That's the reasons for putting it in. I will tell you that I did receive a call from Lisa Tomaso over at the Hospital Association. She said that they are generally supportive of it. They do have a couple areas that they'd like to see us make changes. They're going to send those to us, but they are generally very supportive of it. They want to make sure everybody that works at their hospitals feels safe and secure and is not getting violently attacked at work. So that's it, and I'm happy to answer any questions if anybody has any.
Thank you, Whip. Are there any questions from the committee at this time? Okay. So I just want to let you know, prior to our call-in witness, we do have written testimony from NAGE, Tony Capezza, in favor. Melissa Ferraro, the president of NAGE, is in favor. Jordan Goyette is in favor. And the Rhode Island Department of Health, Dr. Alexander Scott, is in favor. So we will move on to our call-in testimony. Hello, Ms. Blaze. This is Representative Casey, Chairman of the Health and Human Services Committee. You are here on House Bill 6018. If you could state your affiliation and please give us your testimony. Go right ahead.
Oh, thank you, Mr. Chairman and committee. Good evening. My name is Lynn Blaze. I'm a registered nurse over 35 years, currently a recovery room nurse at Fatima Hospital, and I am president of United Nurses and Allied Professionals, representing over 7,500 frontline healthcare workers. Thank you for allowing me to testify in support of this very important bill. I also want to thank Representative Kassar for her work on behalf of our members and all bedside caregivers. All our hospitals have policies on paper about how to address workplace violence, but so many of those instances go under-documented. It's difficult to understand just how bad it's gotten for far too many frontline healthcare workers. This legislation provides critical accountability and transparency. It establishes needed protocols for training and the retention of records. This is a much-needed measure to keep frontline healthcare workers safe. We have come before you in the past to ask for your help to create legislation to protect patients and those charged to care for them. In 2006, you passed the Safe Patient Handling Act, which set forth rules and regulations on the movement of patients. And due to that legislation, we have had marked reductions in staff and patient injuries. In 2008, you passed legislation prohibiting mandatory overtime, which forced hospitals to schedule appropriately and stop risking patient safety by locking in exhausted healthcare workers. I am happy to report that this legislation has worked and the staff no longer have to worry about being mandated into unsafe extended shifts, which has helped improve patient outcomes and staff satisfaction. But today we are in desperate need of your help to pass legislation that will protect the health and safety of every hospital professional. No one should be afraid to go to work, but sadly far too many are. Within the last 3 years, the UNAP has surveyed our members working in hospitals, asking about their experience with workplace violence. Here are just some of the responses. 42% said that they've experienced a violent or near-miss violent episode requiring the intervention by local police. 67% they had personally experienced workplace violence on the job, and 63% said they have at times felt unsafe working in their unit. What has been created in this bill will be the piece we also desperately need. Create a working safety committee, creates and implements assault prevention and protection programs, requires safety training, and if this bill passes, all instances of reported workplace violence will be documented with outcomes tracked. This data will be critical in staffing decisions. This legislation will start to change the culture that is being seen in the workplace, that it's just part of the job. No one should go to work thinking it's okay to be yelled at, hit, spit at, grabbed, kicked, or punched. Just some examples over the past few years at Fatima Hospital alone. We've had an employee admitted to the ICU with a severe head injury after being jumped by a patient. We had another requiring extensive knee surgery after being attacked by a patient. We had a pregnant staff member punched and kicked. Many staff have been spit at, and the verbal assaults are endless. And those are only just a few examples of what the staff has encountered. Thank you for your thoughtful attention and for the opportunity to be heard. Respectfully, I ask that you support this legislation so that in the very near future, I can return to you and tell you that because you passed the Workplace Violence Protection Act in 2021, staff injuries have been reduced and the hospitals are a much safer place to go to work. Thank you for your time.
Thank you, Lynn. Are there any questions from the committee for our witness? Okay, thank you, Lynn. I appreciate your testimony. With that, we will close House Bill 6018. Next, we will move to Representative Tanzi. Representative Tanzi has two bills on the agenda. We will take them one at a time. However, we will take them in order. Representative Tanzi, it's your choice on the bill number. Just let us know.
Okay, great. I actually don't have the bill numbers in.
Okay, I have 6017.
And that's the rate, the insurance rate one?
That is the Public Health and Workplace Safety Act.
the smoke-free one? Okay, I will start with that one then. Good evening, members of the committee, Mr. Chairman. I've been a long-time anti-smoking advocate, and it's always bothered me that we have exempted certain employees from the protections offered to the rest of our state when we enacted the health care or the safety in the workplace statute. I don't know, it might have been 15 years ago now. And smoking and exposure to secondhand smoke are risk factors for susceptibility to more severe COVID-19 symptoms. And it made me really begin to think much more seriously about the impact that this has on our casino workers. So knowing that they're more susceptible to worse outcomes because of their impact on underlying health conditions like diminished lung function, weakened immune system, and associated risk of respiratory illness, now more than ever reducing that exposure to respiratory risk factors seems imperative. And we as a state should do everything we can to remove secondhand smoke from indoor environments and encourage those who currently smoke to quit. 20 states that have casinos already ban smoking, so keep in mind that that number only reflects those who allow casinos in their state. But 87% of Americans are non-smokers. So it always struck me as odd that we, who are the non-smokers, are so disproportionately impacted by the desires of 13%, even though we know there are such difficult outcomes as a result of smoking. So employees in casinos and other gaming venues often face greater exposure to secondhand smoke than employees in other workplaces. In fact, studies have shown that secondhand smoke exposure levels can be up to 18.5 times higher in casinos than in offices, and up to 11.7 times higher than in restaurants. Despite this high level of exposure to smoke, and despite the Surgeon General's finding that secondhand smoke exposure is toxic and causes lung cancer, heart disease, asthma, sudden infant death syndrome, many casino and other gambling venues are shielded from smoke-free laws. That was a decision we in the General Assembly made many years ago, and I think it's time for us to change that. We really do know better at this point. The main argument against this has been loss of revenue, and I should say it's fear of a loss of revenue. There have been many studies that have done, although unfortunately none in recent years, that have shown that the losses are negligible. In fact, New Mexico just passed a bill similar to this out of their House, and their fiscal report said clearly that there was a minimal impact, that any offsets would be gained by savings in health care costs because so many workers receive Medicaid, being such low-wage workers. So I have a copy of that fiscal impact report if anyone is interested. And there is one other issue where the state, we make the laws, that also gives us an increased liability for any class action lawsuits that might be brought against us. So if common sense and good plain logic doesn't, inspire you to change this law, we could also be on the hook for individual casino employees or class action ones may try to form a lawsuit in order to come after the state for leaving them vulnerable to such conditions. So I'm happy to take any questions that anyone may have.
Thank you, Representative Tanzi. Are there any questions right now from the committee? We do have one witness that's going to be with us virtually. We'll take that right now. Hello, Elizabeth Seaver.
Hello, Chairman. How are you?
I'm doing fine. You are with the House Health and Human Services Committee on House Bill 6017. You have the floor and our attention. Please go right ahead.
Thank you, Chairman, members of the committee. Good evening. My name is Elizabeth Seaver, and I'm here on behalf of Bally's Corporation as the Vice President of Government Relations. As we are, we were formerly known as Twin River, but we are the company that owns and operates Twin River Casino and the Tiverton Casino Hotel here in Rhode Island. We are here today in opposition of House Bill 6017. And we are concerned for a couple reasons about this piece of legislation. First, I want to say is that it would really put our two Rhode Island casinos at a competitive disadvantage relative to casinos in neighboring states. As you heard the sponsors say, in other states they have done economic impact studies and said that it doesn't have an impact. But here in Rhode Island, as we're all aware, our residents can drive easily to casinos in neighboring states where they would be allowed to smoke in the casinos. So we are concerned about putting ourselves at a competitive disadvantage in the state of Rhode Island relative to our close by neighboring casinos. But for those guests that currently want a smoke-free experience in the two Rhode Island casinos, we do have designated smoke-free areas within both. So we want to make sure that everyone has the best possible gaming experience when they are with us at either one of the two facilities. And so we think that we are able to do that by allowing a smoke-free area or multiple smoke-free areas within both casinos. I also want to state that although it's not before this committee, we do have a bill pending. It's before House Finance right now. It's H5223. And if that bill were to pass, it would allow us to expand the Twin River property in Lincoln. And as part of that expansion, we will be upgrading the casino's HVAC system, which would greatly improve the air quality throughout the entire casino, not just that of the smoke-free areas. But again, I want to reiterate that we do remain opposed to this legislation because we really believe it would put us at a disadvantage relative to the casinos in the neighboring states. With that, I'd be happy to take any questions that you have.
Thank you, Elizabeth. We have a question from Rep. Geraldo. Go ahead.
Thank you, Mr. Chairman. Can you speak a little bit about how you are protecting your employees from secondhand smoke and policies and practices that you have in place just to keep them safe?
Yeah, that's a great question. I mean, right now, most of our policies and procedures on air quality, frankly, are dealing with COVID, to be completely candid. So we have a lot of policies in place about making sure that people are appropriately distanced and there's appropriate. Relative to secondhand smoke, I'll be able to provide you with this information after the hearing if that would be appreciated.
Yeah, but thank you for that. I appreciate that. But even in a general sense, can you just talk about the policies and practices that you have pre-COVID to protect your employees that are working in the smoking section from secondhand smoke?
Yeah, so we do have HVAC systems in place that are filtering the air constantly, but in terms of particular procedures that we had, I'd have to get back to you on.
Okay, so thank you for that. If I got that right, as of right now, the primary practice is the primary protection is the HVAC system that's in place, which will likely be getting upgraded anyways when there's some work going on. And you'll send me some additional information on other policies and practices that you have after the meeting.
So I just want to clarify that it's not the only procedure. It's the only one that I have information of it with this hearing. So there are I will be able to get you more details about everything in its totality after the hearing.
Thank you. The phone line was breaking up a little bit as you were speaking, so I appreciate that clarification.
Thank you, Representative Geraldo. We're going to Representative Speakman and then Representative Fogerty.
Thank you, Chairman. Ms. Siebert, you said that neighboring states allow smoking in their casinos. Which states are those?
That is Connecticut.
It is?
Yes.
Massachusetts?
Massachusetts is not.
Okay, thank you. And can you tell me what kind of health insurance you offer to the employees at the casinos in Rhode Island?
I will be able to provide that information to you.
Representative Tanzi suggested that some of them are on Medicaid. Do you know if that's the case?
I do not, as I sit here right now.
All right, I'd appreciate the answer to that question if you would. Thank you.
No problem. Be happy to.
Thank you, Representative Speakman. We'll go to Representative Fogerty for a question.
Yes, Elizabeth, do you have a plan in place for if there is lawsuits brought upon by employees who develop cancer from working in the casinos? Is this something that Bally's is looking at in the future? Because, I mean, again, if people are working in these casinos and do develop there's some type of, lung cancer, I would think that Bally's would be prepared for something like this. Do you know what their plans are? And if you don't, could you get us some information regarding that?
I just want to make sure I heard you clearly. You're seeking information on what plans Bally's has to address workers who have or become symptomatic of lung cancer. Is that correct? I heard papers too while you were speaking.
If they have a plan for secondhand smoke from the people that work there, I mean, I'm sure this has probably happened at some of their other casinos across the country. Have they been sued before, and what plans did they put in place for unemployed and have developed some type of, some health condition after working in the smoke-related industry of the casino?
Yeah, I'll be able to get you that information as well.
Oh, you don't know anything about that off the top of your head right now, though?
No, off the top of my head, I am unaware of any such lawsuits, but I will speak with the general counsel for Bally's to get you any information that exists on that and any policies that have been put into place as a result of any lawsuits.
Thank you, Representative Fogerty. We have a question from Representative Ackerman.
Yeah, I think it's more of a comment. I believe that the closest casino is the most competitive to you would be the one in Plainville, and I believe that one is completely smoke-free. Is that correct?
So, actually, depends on where you live in the state of Rhode Island. But that is what I said to one of the questions earlier, which was Massachusetts is smoke-free. So Plainville is in the state of Massachusetts, so it is smoke-free. And I believe, and then so it's Connecticut that allows smoking in their casinos.
Thank you, Representative Ackerman. Representative Potter has a question.
Thank you, Mr. Chairman. Ms. Seaver, do employees at the casino have a choice to choose between whether they work in the smoking or the non-smoking section? Is that optional for them?
I will follow up and I will get you information on that.
Thank you.
Mm-hmm.
Thank you. Are there any other questions from the committee at this time? Okay, before we close the hearing, I just would like to let you know we do have written testimony from Bally's Corporation against the bill. Written testimony from the American Cancer Society, the American Lung Association, the American Heart Association, the Campaign for Tobacco-Free Kids, and from the Rhode Island Department of Health that are all in favor of the bill at this time. Representative Tanzi, would you like to make any closing comments before we close this bill?
No, I did not realize I would have that opportunity, but the questions in the room really did help clear up some of those questions, so I thank you all for the thoroughness.
Okay, Ms. Seaver, thank you very much for your testimony. We're going to close House Bill 6017.
Thank you, Chairman.
Thank you. We're going to move on to Representative Tanzi's next bill. It's on the first page, item number 2 on the agenda, 5842. This is regarding food and drugs, prescription drug cost protections. Representative Tanzi, you can go ahead on House Bill 5842, please.
Thank you, Chairman. This bill is really, to me, a very exciting opportunity. We all know that the United States and Rhode Island ourselves have struggled for years to get healthcare costs under control. And this legislation that's before you right now is new model legislation that was developed for states by the National Academy for State Health Policy. And what this bill does is it sets a maximum or a ceiling for costly drugs so that we can finally begin to control, get that cost under control. So what this bill would do is use the Office of the Health Insurance Commissioner. I know that since this was model legislation, it does refer to this person as the Superintendent of Insurance, but in Rhode Island we call that the Office of the Health Insurance Commissioner. So the Health Insurance Commissioner would determine the payment rates for Rhode Island's 250 most expensive drugs based on a market basket of international rates. So what we're planning on doing, we've all heard that overseas, these drugs are much less expensive. We've all wondered why. We've heard that we're responsible for a lot of the research and development, that as a wealthier nation, that we should be able to shoulder that burden. And I think Rhode Islanders and individuals are finally fed up with this and are finding a way to fight back, and this model legislation is one way to do that. We found out that there are many who are illegally importing these drugs from Canada, from Mexico. We've even had states attempt to do their own importation from Canada. And what this bill does is give us an opportunity to import the prices while maintaining our own oversight through our own FDA, and just import the benefits of their pricing. We would use the Canadian pricing, which is based on a market basket from, I want to say, like 12 other countries: Australia, Belgium, France, Germany, Italy, Japan, Netherlands, Norway, Spain, Sweden, and the United Kingdom. And it takes those prices and it creates an average ceiling that those nations pay. I've provided you with I'm sorry, it's a very poor copy. I just made it in the judiciary room. But essentially what it does is it shows you the opportunity that this presents for Rhode Island if we were to pass this legislation. So Humira, one dose of this on average is $2,706.38. The Canadian reference rate is $541. That's an 80% savings. Our customers would be saving $2,165. Enbrel, $1,353 in Canada, and in other nations, they pay $272. Again, an 80% savings. There's a list of, I want to say, 6 or 7 medicines that are here. A 73% savings overall for our U.S. consumers. Again, it's what other nations are paying. There's no reason why we should not be included in that. States where this has been introduced, other than Rhode Island, are in Maine, North Dakota, Oklahoma, and Hawaii. In North Dakota, it's already passed the full Senate. In Oklahoma, it's passed the Health Committee and Appropriations Committees. Again, this is the first year that this model legislation has come out. I'm happy to answer any questions that you may have. It is relatively new. I will do my absolute best to answer your questions, but I believe there is someone from the National Academy for State Health Policy who's phoned in, and he or she may be able to answer your questions as well, but happy to take any.
Thank you, Representative Tanzi. Are there any questions right now for the sponsor of the bill? Okay. If not, we will move to the witnesses. Hello, Nicholas.
Mr. Chairman, how are you?
I'm doing fine, Nicholas. Welcome back to the Committee on Health and Human Services. This is Chairman Casey. We have before us House Bill 5842. If you would go ahead and give your testimony.
Thank you, Mr. Chairman. I appreciate you having me again tonight. For the members of the committee, my name is Nicholas Doherty. I'm the Director of Policy at Pharma for the New England region, and I'm located up in Boston. Pharma represents the country's leading innovative biopharmaceutical research companies. Since 2000, Pharma members have invested nearly $1 trillion in the search for new treatment and cures, including an estimated $83 billion in 2019 alone. So I am here to testify in opposition to this bill. We did submit a very detailed statement to the committee that provides greater overview of our concerns, and we also included a chart that highlights the availability for drugs in other countries that use reference rates. And so for the sake of time, I'll just try to address a few things here. And we completely agree with the sponsor of the bill that patients need concrete reforms that will help lower the price patients pay for medicines at the pharmacy. Some of those ideas that are make monthly costs more predictable, make cost-sharing assistance count towards the plan's out-of-pocket spending requirements, and sharing those negotiated rebates on medicines with patients. But this bill does not address any of those issues. Instead, it's arbitrarily capping drug prices based on a Canadian system that's not comparable to the U.S. nor to Rhode Island, and it's failing to recognize the complexity of the supply chain to the detriment of the patient's access to new life-saving drugs. And this is because the legislation prevents insurers and pharmacies from purchasing medicines that exceed the government set price in Canada. So in this case, the government is deciding that a medicine's price cannot exceed the lowest price in Canada based off the wholesale acquisition cost that does not include any discounts or rebates. So by allowing the government to set the prices at the lowest price in Canada, we feel that this could be restricting patients' access to medicines and result in fewer treatments getting to patients. And that's because if a payer cannot obtain the therapy at the state-prescribed reference rate set by the insurer, or excuse me, the superintendent of insurer, as the legislation states, or if a pharmacy or dispensing provider cannot stock the drug because it cannot meet the state-prescribed price, then the medicine won't be available to the patient. And now the concern we have, American patients have faster access to more medicines than anywhere else in the world. And that's highlighted on the chart that was included with our testimony. So the countries that are using international reference pricing and other price controls, patients are seeing fewer new medicines and they're facing longer treatment delays. So for example, since 2011, nearly 90% of all new medicines launched in the U.S. are available, whereas that's just 46% are available in Canada. And what sticks out for me is that 96% of cancer drugs that are available in the U.S. within the 0 to 2 month window that they come to market, whereas in Canada, it's 59% are on the market within 14 months. And really, it's not just cancer drugs that result in longer waiting periods. On average, it's 15 months longer in Canada for patients to get new drugs. So again, we're all on board with helping patients pay for drugs at the pharmacy counter. We're just concerned that this approach is going to end up reducing the availability of all of these life-saving therapies. And again, additionally, we also are concerned with some constitutional and legal issues by importing drug prices from other countries. So I know I've kept keeping it very brief. Happy to answer any questions the committee might have, but we do ask that legislators vote no on this bill.
Thank you, Mr. Doherty. Are there any questions from the committee at this time for this witness? We have Representative Speakman first.
Thank you, Chairman. Can you tell me, for example, you suggest that American patients have access to life-saving drugs more quickly than Canadians. So, for example, Humira, or one of the, Representative Tanzi has given us a list, Humira, Enbrel, Stelara, Victoza, Truvada, Xeljanz, Epicusa, and Zytiga. Can you tell me what the lag time was for one of those specific drugs between access to that American patients had versus Canadian patients?
So I can't say to the lag time, but I could hear like a phone call, put it on mute, and I heard the start of the conversation. And just wanted to point out that the prices, and I believe the prices that are being referenced on that sheet of paper for Humira are not including the discounts and rebates that go along with the price of the drug. So as drafted, 5842 is only including the WAC cost of the drug, and it's not including any of the discounts and rebates. And what's concerning for pharma is that the rebates totaled almost $175 billion in 2019. So where is that money going to the patients? I know the legislation includes saying that the savings that would be achieved through the reference drugs would be used to offset and reduce costs for patients, but there's already the $175 billion in the system that could be used to contribute towards lowering patients' out-of-pocket costs, as well as other policies of sharing those rebates or sharing the rebates more with the patient at the pharmacy counter.
So the price that Representative Tanzi has given us for Humira at $2,706.38 is not accurate?
So I don't know where the representative is getting that number from, but of course, happy to have more of a conversation of where that number came from, and then to discuss in general how the differences between the two countries. Of course, being very mindful, don't want to get into specific conversations a specific drug company. We represent the interests of the industry as a whole and want to be very careful when speaking about individual pricing issues of companies.
Okay, so you can't answer my initial question, which is, what is the time lag for any one of these, or pick your own drug? How long do Canadians have to wait for a specific drug? You spoke in general terms, and I'd just like a specific example.
We can certainly try to track that down. Again, we do try to, because of the antitrust issues, stay out of individual companies' pricing for drug products. So that was the approach of using more of a general average of, it takes 14 months on average to get to the market in Canada.
Okay. All right. I'll do some thinking on that. Thank you.
You're welcome.
Thank you, Chairman.
Thank you, Representative Speakman. We have Representative Potter had a question.
Yes, thank you, Mr. Chairman. Nick, thank you for your testimony. You had, well, first let me say, we've heard quite a few bills in this committee this year regarding the inflation of drug prices and how unaffordable they are for so many people. But as part of your testimony, you said that comparing it to Canada were based on arbitrary figures and they weren't comparable. And I want to ask you this, and I'm not being facetious, so please don't take it that way. I'm trying to summarize your testimony from my own understanding. Is it fair to say that you're suggesting the increase, this massive increase that we see in what Americans are paying for drug prices in comparison to what Canadians are paying right over the border is the reason why we have more medicines available and a quicker turnaround time and having access to that? Is it fair to summarize your testimony to make that assumption?
So I think the way that the legislation is drafted is that the price of a drug is not accounting for, probably the biggest issue is not accounting for the rebates and discounts that go into it.
I understand that. I'm sorry. It's just a very long, complicated issue. The supply chain is not. It's not something that can be easily summarized in a few words, and that's the challenge that we run into in trying to sort of articulate the issue of, well, yes, the drug appears as the wholesale acquisition cost, and that's one part of it. But then throughout the chain, there are different actors that are including additional prices, so that the apples-to-apples comparison with Canada is not entirely accurate. That would probably, the short way of saying or answering your question. I understand that. I appreciate that. But I'm asking you, is it your contention that is due to the inflated price of prescription drugs that we're paying here? Is that a direct correlation in your opinion?
Well, I mean, I certainly don't want to share my opinion. My opinion, I'm here to reflect the interests of 36 manufacturing companies. I can share the supply chain and how that operates. And a big thing that we should really point out is that this is going to end up being a price control and limit access to patients' ability to get drugs. And it's being based upon pricing decisions of another country. And it's not another country that's comparable. There's 4 or 5 different regions that this legislation would be looking at, and the population of each region is different. And included in those regions, or included in Canada, there might not be a drug that is made it to market. So if the superintendent assigns a drug into the reference rate, regardless of whether or not it's in Canada, a patient is not going to be able to access that drug in Rhode Island. And that's the bigger access concern that we have.
Okay, I have one last question for you.
Of course.
And you're fine not to answer it too, but you have an open forum here, and again, this committee has heard a lot of testimony, and I think I share the same concern that many members have here, that we absolutely have to act on the affordability of drug prices. Do you have a suggestion for this committee for how you would go about it? What is your suggestion for how we lower the cost of prescription drugs?
So, I mean, you could, as I led off in the testimony, one way would be to make sure some cost-sharing assistance count towards the patient's out-of-pocket spending requirements. We've seen over the last about 5 years, 10 years, that a patient's out-of-pocket costs are applying to the deductible rate. So insurance design has changed to make the out-of-pocket costs greater than they had previously been. So that would be one thing. If we were making cost-sharing assistance count towards the patient's out-of-pocket spending. And then again, probably the biggest is that $175 billion of rebates that are going back into the system from other actors in the supply chain, whether that be a PBM, a wholesaler, a pharmacy, even the government. If some of that money is shared with the patient at the pharmacy counter to reduce their out-of-pocket costs, that would day one, that would be something that's helpful for patients at the pharmacy counter.
Thank you, Representative Potter. Are there questions from other committee members at this time? Representative Fogerty?
Thank you, Nick, for your testimony, but I have to say that I think we've chatted before in this, in a meeting in the past, and, coming from working for a drug company for 23 years, in my past life, I know well that we are overpriced in the United States, that other countries aren't priced as high as we are. And yes, Canada sometimes is slower to pick up some of the prescription drugs that we have here, but it's really because we have the deep pockets, and that's why we're being, forced to pay, and our elderly are being forced to pay. So whether the rebates are making it to them or not, they're not. And if you want to say that that's the way the drug companies can work on this, I think that you, as working for all of the different companies, if you want to be on the side of the American people and the elderly, that you would force some of these rebates to be used to offset the cost of the pharmacy. It's not happening. And I think that that the American people have deeper pockets, and they say maybe in Canada or maybe in some of the other countries, but the disease states don't change. Everybody has type 2 diabetes in Canada is the same type 2 diabetes that's in the United States or in Spain or France or England. And the pricing is just really gouging on the pharmacy, on pharma. I know it, I've seen it, I know it happens. They could do less money on advertising direct to the doctors. I get it, some doctors don't open up the medical journals and learn, but the money that's spent just on advertising alone by Big Pharma is ridiculous. And it's getting out of hand, and people just can't afford to have these prices. And some medicines are good medicines, and in the long run, they can reduce the health problems of patients and reduce morbidity and mortality. But people have to, in the drug industry, have to start helping the American people. That's really what it comes down to. Or you're going to have to keep coming back to different houses of representatives across the country and try to explain your WAC prices and your, different discounts. But it's not working here. And people, even for generics, the generic companies, I'm not even sure if they're part of your pharma group, the prices of the generics are outrageous. I mean, something has to be done. I have to say I call total BS on all of this because I know we're paying more, because you know that you can get it from the people who have private insurance, and you can get it from the federal government for the Medicaid and Medicare. So you've got to start working a little harder versus talking about us getting the rebates. I just have to get it off my chest. Thank you.
Thank you, Representative Fogerty. Are there any other committee members with questions for our witness? Okay, Representative Speakman again.
Thank you, Chairman. Can you tell me, I'm confused about the rebate situation. What exactly is that? You seem to be relying on that as the solution to the high cost of pharmaceuticals in the United States. This bill doesn't speak to rebates, it doesn't prohibit them. But can you tell me why you think that's a good answer? How does it work, and why is that a good answer to the high cost of pharmaceuticals? Thanks.
Okay. No, all really great questions. And Rep. Fogerty, I got involved in this. I was in the Massachusetts State Legislature as staff for over 10 years, and this was an issue that I spent nearly 3 years specifically on the supply chain of trying to pick it apart and figure out what was happening. And Rep. Speakman, to your question of how the rebates work, I started pulling apart why my drug costs and my prescription costs at the pharmacy kept being different at different places. And at the time, I went back up to the State House. I talked to my boss. I said, "There's an issue here," and he gave me an opportunity to sort of run with it. And this is how I got involved, recognizing that the price that's set by the drug manufacturer, we'll call it, is the list price. And the list price as it gets to the patient at the pharmacy counter changes. And that's because the drug manufacturer is trying to get the drug on the best tier of the formulary. Because the best tier of the formulary gives the patient the least out-of-pocket cost. So the higher the rebate from the drug manufacturer to a PBM or a pharmacist or a wholesaler, the better placement on the tier. The better placement on the tier, the more the drug is going to be used by the patient. And so that's why there's this disconnect of when someone says the wholesale acquisition cost or the WAC, it does not include the discounts and the rebates. It's disproportionately not accurate. In fact, brand medicines have actually only grown about 1.7, I think, is the number on average, and that's below the rate of inflation, and that's been the case for a number of years. The net that the manufacturers have made has been almost flat, but the list price, and that's the price that everyone is frustrated with, particularly as patients have to pay their deductible because the insurance design has changed, is the frustrating part. And the comments that I made to Rep. Potter when he said, what would you want to make this better? Say, well, you have to change the deductibles and have some sort of way to help patients have some predictability, because typically that high deductible cost comes at the start of the year. So if a patient isn't able to pay out of pocket in January, now we're starting down an adherence conversation. So by bringing up the rebates, that's really an important, view from 30,000 feet, is understanding that there's the list price, and then there's a delta in between what the manufacturer is actually netting. And this is, I think, you'll have to apologize. I'm motioning this with my hands as I'm sitting here by myself, but that's what I would be showing the members, is that there's that delta in between the list price that doesn't account for discounts and rebates. And by sharing those discounts and rebates that are helping the drugs get on the better placement of the formulary, that's low-hanging fruit. Where if you were sharing that with patients, it would really help reduce their out-of-pocket costs.
Thank you.
Thank you. Are there any other questions from the committee for our witness? Okay, hearing none, we're going to move on. Thank you, Mr. Doherty, for your testimony. We're going to move on to our next witness.
Thank you.
Hello, Mr. Dane? Hello, William?
Yes, sir.
Yes, sir. This is
Yes, sir.
Representative Casey, Chairman of the Health and Human Services Committee. You are before us on House Bill 5842. If you would go right ahead with your testimony, please.
Thank you, Chair Casey and members of the committee. I appreciate your time. My name is William Day, and I am the Director of State Government Affairs for the Healthcare Distribution Alliance, otherwise known as HDA, speaking to you in opposition of House Bill 5842 as drafted. HDA is the National Trade Association representing 35 primary pharmaceutical wholesale distributors. These are organizations that work around the clock to connect approximately 1,400 manufacturers with healthcare providers and pharmacies nationwide. House Bill 5842 presents some misrepresentations regarding the healthcare supply chain. As distributors, HDA members do not manufacture, prescribe, or dispense any medications, nor do they influence pharmacy benefit design or reimbursement, or most importantly, set the wholesale acquisition cost, or WAC, also referred to as list price, for prescription drugs. Instead, HDA represents the logistics-focused arm, if you will, of the healthcare supply chain. They purchase products from manufacturers, ensure they are safely stored in warehouses across the country, and efficiently fulfill orders placed by licensed providers. House Bill 5842 confuses drug purchase price and reimbursement. Health plans, including ERISA plans, if they were to participate, do not directly purchase drugs. Rather, they reimburse pharmacies and other providers for drugs provided to their beneficiaries. Pharmacies purchase drugs from manufacturers, often through distributors at list price or WACs established by manufacturers or at negotiated discounted rates. As the bill is drafted, it assumes the pharmacy purchase price and reimbursement are one and the same, and they are not. Furthermore, House Bill 5842 restricts pharmacies from purchasing products in excess of a specified international reference price for certain patients enrolled in state health plans or participating ERISA plans. Wholesale distributors have no insight into patient-level data and have no visibility as to which patients might be enrolled in which plans. Distributors simply don't know when they sell a drug to a pharmacy to whom it might later be dispensed and whether the patient is enrolled in any health plans subject to House Bill 5842. Similarly, retail pharmacies are unable to predict a patient's coverage or medication when ordering from a wholesale distributor. Wholesale distributors' facilities are often located in areas where they can service multiple states from a single source or warehouse. In some cases, they will not maintain offices or personnel in a state. In fact, in many cases, the product arriving in a state may be shipped there by a contracted delivery service or through an existing third-party partner like FedEx or UPS. While distributors may not have facilities or employees in every state, they're licensed and comply with all existing state and federal laws regarding pharmaceutical distribution. Thus, the provision in this language requiring wholesale distributors and manufacturers maintain both a registered agent and office within the state, we believe is overly burdensome. Wholesale distributors already have nexus in Rhode Island per their license to do business. Finally, the enforcement and penalties within House Bill 5842 as they relate to wholesale distributors are of great concern to our members. Simply put, they fall outside the scope of their role. Wholesale distributors are not able to negotiate in good faith, as this bill provides, as price negotiations in regard to determination of the WAC or list price of a product are not within their purview at all. Further, were a manufacturer to opt to remove a drug from market or simply not supply it to wholesalers for distribution in Rhode Island, wholesalers would not have the authority or capacity to alter that decision, yet they would still be subject to the stipulated $500,000 penalty. So for these reasons, HCA respectfully opposes House Bill 5842. Thank you for your time and consideration of our concerns. I absolutely look forward to working with the sponsor on this legislation, and I'm always available as a resource. And with that, I'm happy to answer any questions of the committee.
Thank you, William. Are there any questions for Mr. Dane, our witness? Hearing none, I will let you know that we have received written testimony from the Pharmaceutical Care Management Association. They are neutral on this bill. The Rhode Island Business Coalition is opposed. The National Academy for State Health Policy is neutral. The Healthcare Distribution Alliance is against. Blue Cross Blue Shield of Rhode Island is in favor of the bill. Office of the Health Insurance Commissioner is in favor of the bill. Bio is against the bill, and Pharma is against the bill as well. If there are no other comments from the committee or the sponsor, we will go ahead and close House Bill 5842.
Mr. Chairman, since I recognize that you allowed that, I do have something I'd like to close
If you could be brief, thank you.
I absolutely will. So pharma keeps adapting and changing, and Rhode Islanders keep paying. This bill transforms the landscape to the advantage of Rhode Island ratepayers. They've managed to create pharmacy benefit managers, all kinds of middlemen, and cancer patients should not have to rely on the availability of rebates for their life-saving treatment. There's absolutely nothing in this bill that would prevent manufacturers from offering rebates. This bill offers transparency on costs, not coupons or rebates. So I urge passage. Thank you, Mr. Chairman.
Thank you, Representative Tanzi. That will close the hearing on House Bill 5842. We are going to move to House Bill 6061. That is Representative Fenton Fung's bill. Representative Fenton Fung, you're with us? Representative Fenton Fung, we cannot hear you right now. It looks as though you're unmuted, but I cannot hear you. Nope. My apologies. Okay, let's see if we can fix that technical difficulty. I will move quickly to a bill by Representative Price. For those of you, Representative Price's bill, I believe, is on the end of page 2, House Bill 6015. Before we open the hearing on House Bill 6015, I am going to let you know that Representative Price had some witnesses that wanted to appear, and they could not. So what we are going to do is hear the bill. By our rules, we have to hear the bill, and we will also post this bill for next week. So if you would indulge me, I will read the description of the bill. This is an act relating to health and safety from the Department of Health. It requires the mandatory immunization informed consent form contains certain relevant information. The bill says that this act will require immunization informed consent forms to include language that the vaccine provider has given the recipient a copy of the vaccine manufacturer's package insert listing the vaccine's ingredients, contraindications, potential adverse reactions, including death, as well as the vaccine maker and lot number. Right now, there is nobody signed up to testify in person or by the phone. However, we do have written testimony from Jeffrey Bratberg from Farm D. He is against the bill. Kendra Walsh from Wyoming, Rhode Island, I think it's Farm D as well, is against the bill. Bio, Ben Chandhawk is against the bill. The Rhode Island Department of Health has submitted testimony that the state already does this and federal law already requires it. And the Rhode Island Wellness Society, Christine Waldeck, is in favor of the bill. I cannot answer any questions on Representative Price's bill, so what I will do now is close the hearing on House Bill 6015. This will be posted on next week's calendar as well, so we will see that coming back. Representative Fenton Fung, are you with us now?
No.
Representative Fenton Fung, can you hear me? Okay. We're having some trouble. If you could try to rectify that, we have a few bills to go through, and if we can't get that rectified in this way, we will have you we'll have you called on the telephone, and we'll have you testify as our witnesses do. Is that acceptable to you? You can give me a nod. Thank you. Okay, if you could take a few minutes and try to do that, and we'll come back to you. Okay, everybody. So we have next on the agenda, I'm going to take that one last. We have Representative Bennett. Sir, are you with us? Chairman Bennett?
Here.
Yes, sir. If you would like, you could turn on your video, and I'm going to take House Bill 5864. This is an act relating to behavioral health, developmental disabilities, hospitals. This is the Developmental Disabilities Ombudsman Act. Representative Bennett, if you are available.
Yes.
Okay, sir. We can't see you on the screen, but we do have your voice if you would like to go ahead and testify.
I don't know why you can't see me. Anyways, the Developmental Disabilities Ombudsman Program would help people with disabilities, developmental disabilities, transition from into adult care. This could be a very trying time for somebody with developmental disabilities, going from what they're used to, what they're familiar with, and going into a different type environment. The ombudsperson would be voted in by a committee appointed by the governor. What they would do, they would have to have expertise and experience in the field of social work, long-term care, advocacy, and qualified and experienced in the provision of support services to adults with developmental disabilities. The definition of students with developmental disabilities is in transition to adult services means a person 16 to 21 years old who is transitioning from special education services to adult services and is either a person with a developmental disability or a person with a severe chronic disability. As I said, this is a very difficult time, and they need advocacy, someone that understands the field and help them to transition into the right, whether it be group home, educational, social. But as it stands now, some of us know that we've known people that chronologically, they say you're at a certain age and you're done, you're out. And it's devastating to these people. You know, they don't know why. They take it as a punishment, or they did something wrong, you know, and they're removed from their normal setting. I know I have witnesses that are a lot better equipped to give you the finer details of this, so I'll stop there and I hope I have witnesses. I haven't seen the list, but I'll take any questions if I can answer them.
Thank you, Chairman Bennett. Are there any questions from the committee for Chairman Bennett? Representative Geraldo, go right ahead.
Thank you, Chairman. Chairman Bennett, in his written testimony, Tim Ryan said that this would likely add to the existing bureaucracy, making it more difficult that would lead to more conflict. Can you, and break down the cooperation that it currently exists between existing organizations? Can you speak to that a little bit? Do you think that would happen? Do you think that adding another official would make the system more complicated? Or obviously, I assume that you feel differently, but can you talk about why that might be?
Well, the developmental disability person would find it easier because they'd have somebody to speak up for them. The families would find it easier. I am not familiar with whosever testimony you just read. I haven't had the privy of reading it. I'm sure I got Bob Marshall coming up, I believe, to speak. And he's from the Rhode Island Developmental Disabilities Council, and I'm sure he can speak on that issue. As far as making it difficult, it depends on who you're looking at to call it difficult. You know, if you're looking at the family and the developmentally disability person, that's who I look at because that's who needs the advocacy. But you know, it'll be appointed by the right people, by a committee, and I don't know what you mean by the difficulty, so I'm going to let Bob Marshall handle that.
Thank you.
Good enough.
Thank you, Representative Geraldo. Thank you, Chairman Bennett. Are there any other questions from the committee at this time? Okay, if not, we have one calling witness. Again, Mr. Robert Marshall, he was on with us before. Hello, Mr. Marshall, thank you for joining us again. You're here on House Bill 5846 from Representative Bennett. If you would please go ahead with your testimony.
Okay, thanks again. I'm testifying on behalf of the Rhode Island Developmental Disabilities Council. This is an issue we've been working on for quite some time, and I just want to say the bill was a little larger than what has been talked about so far. It does deal with that transition period, but it also deals with adults that have developmental disabilities and things that happen while their services are being delivered, and advocating for their services to be the type and quality that they want. So it basically picks people up when they are about to transition, that 16 to 21, and then follows them through the rest of their service with Buddha once that transition is made. As far as the question that was asked relative to how this would interact with the schools, this addresses a problem that many of the people transitioning have, in that, you know, they've gone through the schools. Most people with developmental disabilities start school early. They start when they're 3 years old, and they carry through for the most part until they're 21. So they have a long-term relationship with their local school district and have, you know, figured out how to get the services they need so that they can get through the educational process like everyone else and come out the other end with a diploma, hopefully. But then after that, many of them need continuing services in adulthood from Buddha. And we have tried for years to figure out a way to make that transition happen smoothly. And it's gotten a lot better. And it's not really either organization's, I think, issue that's making it not work. It's more that there's this cliff that happens on a birthday, and all of this support system that this individual and his family have built up through the school years suddenly goes away, and now they find themselves in a totally different situation with a totally different agency, and, you know, trying to figure out how to make that work. And what often happens is it falls apart for a little while for many people there, and they end up spending, you know, anywhere from a month to a couple of years sitting on their family's couch, waiting for everything to get straightened out. And that's what we're trying to address, is make sure that that doesn't happen for anyone. I have been in touch with Superintendent Ryan. I called him as soon as this bill went in. And I think we can address his concerns. I think, you know, and he basically said that things have gotten better, and they have. No one's denying they have. But it's not working for everyone yet, and that's what we need to get to. So since we've been working for quite a few years on putting an ombudsman person in, similar to the nursing home ombudsman, the people that live in group homes for the rest of their life, or live in supported living, or those kinds of situations, that someone is there when things go wrong, that can step in as the nursing home ombudsman do, and make sure people's rights are maintained and all of that going through while they're dealing with the state agency that's funding them and the provider that's providing their services. And that was what we were working on, and then it made sense to add in this piece to deal with the transition part and get that person involved earlier during that transition period so that they could start educating students to what their rights are going to be in the adult service system and help them across that cliff so that they don't end up falling apart, because that's what happens is the end of that last school year, you no longer can go back to your school teacher and say, hey, this isn't working, I need to fix it. And you have these other people that you now have to go to that, you know, you've never worked with before. And I think if there's one agency that bridges that gap, it'll make it much easier. I talked again to Mr. Ryan this morning, and it was an oversight when we were drafting this also that I brought up with him, that in that appointment committee, we didn't, since when we did the first draft, we weren't looking at including the education piece. We forgot to put in an education person on that appointment committee, and that's a sub-A that we're very happy to work out with the superintendents and, have one of them sit there so that we have all of the other, the providers have someone there, Buddha has someone there. And the whole point of that committee is so that we don't get someone appointed that one of those parties can't work with, because that would not help the individuals that are involved. And so that's why we want those all of the involved parties to come up with a list that the governor can pick from, and then appoint a person that everybody can work with that will make sure that the rights of the consumers with developmental disabilities are respected and that the services are delivered appropriately. Be happy to answer any other questions the committee might have.
Thank you, sir. Are there any questions from the committee at this time? Okay. Hearing none. Just one moment. I want to check if we have some testimony here. Okay, we do have written testimony for 5846 from the Rhode Island Developmental Disabilities Council. They are in favor. The ACLU of Rhode Island, they have no formal opinion. They're looking for a clarifying amendment, so they have written in testimony with a clarifying amendment. The Governor's Commission on Disabilities, Bob Cooper, is against this bill. And the Rhode Island Superintendents Association, represented by Tim Ryan, is against this bill. Are there any other comments for the committee members before we go ahead and close this bill? Okay, House Bill 5846, the hearing is closed. We will now move on to House Bill 5937, and that is by Representative Ranglin Vassal. House Bill 5937 is a House resolution to create a special legislative commission to study the impact of trauma inflicted on children exposed to violence. Okay, and Mr. Marshall, you're still with us? Is Bob still with us? Okay, he's going to testify. While we're getting Bob back on the phone, we did have written testimony on this bill from the Sisters Overcoming Abusive Relationships, who are in favor of the bill. Rhode Island Coalition Against Domestic Violence is in favor of the bill. The Rhode Island Developmental Disabilities Council, they have a suggested amendment, which is in the written testimony. Jordan Goyette is in favor. Family Services of Rhode Island, Margaret Holland McDuff, has a suggested amendment, and also a group called SOAR, S-O-A-R. Callie Babbitt Spears, they are in favor of the bill. And we do have Mr. Marshall on the phone, so we'll grant him some leeway. Mr. Marshall, if you would, please go ahead with... Mr. Marshall, this is Representative Casey again. If you would go back, go ahead with your testimony on House Bill 5937, please.
Thank you. Again, hearing on behalf of the Rhode Island Developmental Disabilities Council, we are very much recognize the need for to evaluate and plan based on the effects of trauma on both children and adults. And over the last few years, we've done quite a bit of work in this area with bringing in people from other states that have addressed this, so that we can help Rhode Island move towards a trauma-informed state. And as a result of that, we have brought together a lot of clinicians and parents and advocates, and formed what's called an Ocean State Trauma-Informed Community Coalition. And so our suggestion is that the commission that you're proposing be expanded by 2 and have a seat for someone from the Developmental Disabilities Council and someone from the Ocean State Trauma-Informed Community Coalition on the Special Legislative Commission, so that we can bring some of the research and things that we did to this commission, and help it move this issue forward. Be happy to answer any questions.
Thank you, Mr. Marshall. Are there any questions for Mr. Marshall regarding the proposed resolution for a special legislative commission? Okay, there are none at this time. Okay, with that, thank you, Mr. Marshall. We appreciate your testimony. I will close House Bill 5937 by Representative Ranglin Vassal. We're going to go back to Representative Barbara Ann Fenton Fung for her bill. It is House Bill 6016. I believe we have overcome our technical difficulties. This is for a House resolution respectfully requesting the Department of Health to establish guidelines and protocols for administering vaccines in the safest possible method to persons undergoing immunosuppressive therapy. Representative Fenton Fung, you have the floor. Go right ahead, please.
Thank you so much, Chairman Casey, and thank you to the entire committee. My apologies for the technical glitches here. This is the easiest bill all night. Basically, it came out of a couple of my constituents who were unable to schedule the vaccine. That was in the safest way possible for them. A lot of my constituents who are undergoing chemotherapy right now have been advised by their doctors to only take it in these little windows, whether it's 1 or 2 days before their next chemotherapy cycle or whatnot, and it's been very, very difficult to schedule those appointments and coordinate that with either local clinics or state-run clinics. Right now it's kind of like grab the first available, and sometimes the local clinics don't even meet on the days that would work for these patients. So when we look at that, the scheduling issues, and also our desire not to want to expose them to other germs that might be in a mass vaccination clinic setting, we're just asking the Rhode Island Department of Health to allow the local cancer clinics to administer the vaccines themselves. Right now they currently aren't able to do that. So that way they can coordinate best with their doctors, timing-wise, and also keep them as safe as possible from an infection control standpoint. Very simple. I'm happy to entertain any questions. Thank you.
Thank you, Representative Fenton Fung. Are there any questions from the committee regarding this legislation? Okay, Representative Speakman, go right ahead.
Yeah, thank you, Representative, for bringing this forward. It strikes me that this needs quick action, and I don't know if someone can just call someone and make this happen. Our process, it doesn't work very quickly, but thank you for bringing this to us, and I would hope that there's a more expeditious way to manage this. But, I mean,
I appreciate that greatly, yes, Representative. I have talked to the Department of Health, and that has not happened quite yet, so we're going this route to try to put some more pressure.
Maybe Chairman Casey should make the call.
Well, thank you very much for volunteering me, Representative Speakman. Representative Fenton Fung, I'll have a conversation with you offline about this if you would like.
I appreciate it.
And if there are any other questions, we'll hear those questions from the committee. Okay, hearing none, I'm going to close the hearing on House Bill 6016.
Thank you.
Representative, you can feel free to send me a text, and I will get back in touch with you. Thank you very much. Okay, we're going to move on to the last bill tonight. Don't get all excited. We do have quite a bit of testimony for it. Everybody thought we were getting out a little bit early. This is a House Bill 5612. This is by Representative William O'Brien. An act relating to health and safety. It is the Consumer Protection in Eye Care Act. I will read a brief summary. The bill itself is quite lengthy. This act would provide consumer protection in eye care services by developing standards and enforcement protocols related to the utilization of assessment mechanisms in the provision of eye care services. And before we get to the call-in testimony, I will let you know that the written testimony, we have written testimony from RIOH, Robert J. Parks, in support of the bill. The Americans for Vision Care Innovation are in opposition. The American Telemedicine Association, Kyle Zebley, is in opposition. The Rhode Island Business Coalition is in opposition. Warby Parker is in opposition. Chris Grimney is in opposition. RIBIO, Carol Malses is in opposition. R Street Institution, Courtney Jocelyn is in opposition. The National Taxpayers Union, Luke Vukmir is in opposition. And Angel Lopez is in opposition. That was all of the written testimony regarding this legislation. Representative O'Brien was unable to be with us tonight to introduce the bill. We are going to go ahead and move on to our first caller. Hello, Mr. Grimm? Hello, Mr. Grimm?
Yes, sir.
Yes, sir.
Yes,
This
sir.
is Representative Casey, Chairman of the Health and Human Services Committee. You're before us on House Bill 5612. If you could please state who you represent and go ahead with your testimony.
My name is Christopher Grimm on behalf of Warby Parker, testifying in opposition to House Bill 5612. Mr. Chair, members of the committee, thank you for the opportunity. Warby Parker is a vertically integrated eyewear brand founded in 2010 with a simple mission to provide designer eyewear at affordable prices. We have a number of retail stores as well, in addition to our online presence, including at least one store in Rhode Island. By circumventing traditional channels, we're able to provide designer eyewear at a fraction of the cost. As cheap as $95 compared to a couple $100 elsewhere. Also, in 2017, we launched Prescription Check, which is a mobile application that gives our customers a safe, convenient, and affordable way to renew their glasses prescriptions. Prescription Check is a standard vision test. Patients have to have a current, existing, non-expired prescription, which means that they have had their prescription renewed within the last year, I believe, in Rhode Island for glasses. They go through this vision test. They submit a medical history questionnaire, and a ophthalmologist licensed in the state that the person lives in reviews the data, reviews the test, reviews the medical history, and if the patient passes the vision test, that means their current prescription is still valid, and they will renew that prescription. We operate within the guidelines of the American Academy of Ophthalmology, which states for asymptomatic individuals or individuals without risk factors who are 40 to 54 years old, who have had a comprehensive eye exam, the recommended interval for evaluation is 2 to 4 years. That is for people 40 to 54. Younger than that, the recommendations are up to every 4 years. House Bill 5612 would require all patients, regardless of their age or medical history, regardless of the discretion of the ophthalmologist, who is a medical doctor, who took an oath to do no harm, who is licensed, who has experience in these matters. This is the state mandating that what the patient wants and what a licensed ophthalmologist in the state wants does not matter. The American Optometric Association has their own guidelines. Their guidelines are that for patients under 64 to receive an eye examination at least every 2 years. Part of the impetus that we believe is behind this bill is the fact that more than 50% of optometrist revenue comes from the sale of glasses and frames in their store. One of the reasons why we launched Prescription Check is because people were frustrated with having to receive frequent medically unnecessary examinations where they are given the hard pitch, the hard sell to buy glasses. We offer glasses significantly cheaper. We run our telehealth option Prescription Check in line with the guidelines from the American Academy of Ophthalmology. We supported legislation in a number of states that verified and supported ocular telemedicine in Indiana, Minnesota, Washington, and Virginia. Those states put some common sense guidelines in place. In Connecticut and Kentucky, laws were passed that we did not fully support because they were legislating standards of care, just as this bill would, that are not in line with the American Academy of Ophthalmology guidelines. Georgia and South Carolina are the only states to ban the use of ocular telemedicine entirely. There's no medical reason to prevent ophthalmologists from using their clinical judgment to decide whether prescription check and tools like it are appropriate. The other issue with this bill is it requires providers using telemedicine to verify that a patient has received an in-person comprehensive exam in the last 2 years without any infrastructure, without any means for doing that verification. Optometrists do not have to load data up to like any central database. There's no way for an ophthalmologist to verify when someone's last in-person exam was. And I believe that that requirement was added to this bill in full knowledge that that is impossible to make this a ban. Because that is what this bill would essentially do. It would ban the use of ocular telemedicine in Rhode Island. In light of COVID-19, states are expanding their use of telemedicine to treat various health conditions. Rhode Island should not be going in the opposite direction and create new restrictions on one of the safest forms of telemedicine available. Thank you. I urge everyone to reject this bill, and I'm happy to answer any questions.
Thank you, Mr. Grimm. Are there any questions from the committee regarding this legislation? And the witness? Okay. Mr. Grimm, thank you for your testimony. We're going to move on.
Thank you.
Hello, Mr. Zebley.
Hello, good evening.
Hello, Kyle. You're here with the Health and Human Services Committee on House Bill 5612. If you would go ahead and state who you represent and go ahead and give your testimony.
Thank you so much to the chairman. Thanks so much to the committee for hearing me today. I am Kyle Zebley. I am the Director of Public Policy at the American Telemedicine Association. And on behalf of the ATA and the over 400 organizations we represent, I'm just speaking today to express our opposition to House Bill 5612 as currently drafted. Over the last 4 years and throughout the ongoing pandemic, the use of the appropriate telemedicine technologies and the delivery of ocular care has benefited patients across Rhode Island. House Bill 5612 represents a step backwards for Rhode Island State telemedicine policy as it relates to ocular care, as it would make it much more difficult for Rhode Islanders to access their ocular care services in a safe and efficient manner. First, the ATA opposes in the bill specifically that in 23-95-4, which would prohibit optometrists and ophthalmologists from using data and information obtained from assessment mechanisms as defined in 23-95-2 as the sole basis for issuing an initial prescription for contact lenses or a follow-up or first renewal of the initial prescription. This proposed prohibition on the use of this technology has no clinical basis and is unsupported by peer-reviewed studies. As such, it is an arbitrary anti-competitive barrier to affordable quality care. As patients and consumers seek out more convenient and affordable means of accessing healthcare services, state legislatures should not pick and choose which modalities are more appropriate than others in the delivery of those services. Instead, lawmakers should defer this decision to licensed medical professionals who are qualified to determine which technologies are necessary to meet the standard of care for the condition presented by the patient. This provision would ban the use of technology in the delivery of ocular telemedicine in Rhode Island, reversing a policy that has benefited thousands of the state's residents throughout the last 4 years by allowing them to renew their contact lens prescriptions from the comfort and safety of their homes. Additionally, our organization has concerns about language in the bill, which requires patients to have an in-person eye examination at least once every 24 months before receiving visual aid glasses or contact lenses. While the ATA understands that the legislature wishes to maximize patient safety, the 24-month condition presented in House Bill 5612 is both arbitrary and clinically unjustified. And according to the Centers for Disease Control and Prevention, recommendations as to how often patients should engage and an in-person examination are formulated by ocular care professionals after taking the patient's age, medical history, and other factors into consideration. Practitioners may instruct their contact lens wearing patients to receive a yearly contact lens check. However, this can be done effectively and safely using the appropriate telemedicine technologies. Mandating that patients receive in-person examinations every 24 months in order to obtain their glasses and contact prescriptions presents unnecessary barriers in their efforts to access ocular care. The ACA maintains that licensed healthcare professionals can leverage the innovations in technology to reach more patients in a more affordable manner. Arbitrary requirements that mandate in-person office visits presents barriers to patients who want to access healthcare through telemedicine technologies. Such requirements that are presented without clinical substantiation should be viewed as anti-competitive provisions and thus not in the public interest. Thanks so much for the committee for their continued interest in ocular telemedicine. We urge you and your colleagues to consider our concerns and the consequences for Rhode Island patients if this legislation were passed in its current form. And of course, we here at the ATA are absolutely happy to work with you on this legislation and ending up. Thanks so much.
Thank you for your testimony. Are there any questions for our witness? Okay, hearing none. Kyle, thank you. We're going to move on to our next witness.
Thank you so much. We are absolutely happy to work with you on this legislation and ending up.
Hello, this is Chairman Casey from the Health and Human Services Committee. Who am I speaking with?
Hi, Mr. Chair. This is Nick Shilligo, representing 1-800-CONTACTS.
Hi, Nick. How are you today?
I'm doing well. How are you?
Thank you, sir. I'm doing fine. We are here with House Bill 5612. You have the committee's attention. If you would keep your testimony brief, go right ahead, please.
Yes, sir. Thank you. And members of the committee, thank you for allowing me to testify in opposition to House Bill 5612. As I mentioned, I represent 1-800-CONTACTS. We are the nation's largest contact lens retailer and have more than 15,000 customers in the state of Rhode Island. We are also a member of the Americans for Vision Care Innovation, a bipartisan coalition of consumer groups, trade associations, think tanks, and companies advocating for innovative technologies that promote low-cost access to vision care needs for underserved populations. Online vision testing platforms like ours have provided access to contact lens and eyeglass prescription renewal services in the state of Rhode Island for over 4 years. These services allow a Rhode Island licensed physician to determine if they can, if the platform can be used appropriately based on each individual patient and their unique medical needs. These services increase access to health, save consumers time and money. This bill would effectively ban the use of these platforms, taking a step back in access to care via telemedicine. This is especially troubling as we are still dealing with the effects of COVID and have seen tremendous growth in patient access to and preference for convenient, low-cost access to care. During the last 4 years, we as a company have offered and provided more than 1 million tests conducted in almost 40 states nationally, and at this time, we are unaware of a single adverse event, malpractice claim, or consumer-driven complaint to a medical board in any state that we're operating in. We believe that this data alone demonstrates that these services can be used safely and effectively, and I appreciate your time once again, and I'm happy to answer any questions.
Thank you, sir. Are there any questions for Mr. Shilligo? Shilligo. Okay, hearing none, sir, we're going to move on to our next witness. Thank you for your testimony.
Thank you, sir.
A quick question.
I'm sorry, you still with us, Nick?
I am, yes.
Okay, Nick, hold on. Representative Fogerty has a question for you.
Nick, are there other states like that you don't do any of these contact vendor services in? I know my mother-in-law lives in Kentucky, and she said something about you guys didn't have that type of a service there. Is there some states that you do and you don't have services?
So there are two business lines that we operate under. I think what you asked about is the distribution of contact lenses. So we operate in all 50 states and are allowed to dispense prescriptions in all 50 states with a valid and verified prescription. And then the other one is what we're talking about here today, which is our Express Exam, which is our online vision testing platform. We're currently operating in about 40 states. Kentucky is one of them. We went through a similar debate on that issue in Kentucky several years ago, and we continue to be able to operate services there currently, yes.
But Rhode Island, this bill is objectionable because if it was not...
The bill itself, is that what you're referring to? I mean, we're operating in Rhode Island now under the regulatory authority of the medical board and the licenses that they would provide to the physicians that we use to offer services, to deliver those services. The language in the bill specifically that we have concerns about, the most impactful, I guess, we see is actually effectively banning the use of the technology. So when you look at the language around assessment mechanism, it is defined as something, a service or platform that would be operated on by a phone or a computer, two things that most individuals have access to. However, there's some language in the bill that restrict prescribing and renewing prescriptions based solely on information collected by those devices. And so if you can't collect the clinical data using a platform that is attached to consumer products like a computer or a smartphone that someone can use in their home, then I don't know how you would be able to access any platform, because the whole point of them is that they're attached to computers and smartphones and other types of devices that collect that clinical data that's then forwarded to the ophthalmologist, the board-certified ophthalmologist, to determine whether or not they can renew the prescription. And so we read that as effectively banning the use of the technology if you can't do it through those means and mechanisms.
Okay, thank you.
Yes.
Thank you, Representative Fogerty. Are there any other questions from the committee? Okay, Nick, thank you for your testimony, and we're going to move on this time for sure.
Thank you.
Hello, Mr. Walsh. This is Chairman Casey. You are here with the House Committee on Health and Human Services on House Bill 5612. If you would go ahead with your testimony, please.
Thank you, Mr. Chairman and members of the committee. Bill Walsh here on behalf of the Rhode Island Optometric Association in support of H 5612, the Consumer Protection Eye Care Act. I'd certainly like to thank Representative O'Brien for sponsoring the legislation, which is all about establishing responsible guardrails for the use of technology in eye health care, in particular as it relates to issuing prescriptions for glasses and contacts through applications. To be clear, this bill does not ban technology. It ensures that providers use these technologies consistent with the standard of care of in-person clinical settings. And these standards come from laws like Kentucky and Connecticut. I appreciate the line of questioning that was just raised by Representative Fogerty to point out those two things. Much of this bill, if not all of it, comes from language in those states that are already in effect. And we heard testimony from the gentleman from 1-800 that they operate there. So what's the real question? Do we just not like regulation whatsoever? And certainly they prefer not having any guardrails in place because it allows them to proceed as they see fit. But we don't think that's fair for the patients here in Rhode Island, and we certainly don't think it's a good consumer protection issue to leave it unregulated. So what kinds of standards are we talking about? For the technology, the bill requires that it create an interaction between a provider and a patient, either simultaneous or later, that it collects key information like medical history, prior prescription, date of last exam, and it discloses to the patient the scope of the use of the technology. And for where we focused even more closely this year was about this language that's on the provider, because we view them as an appropriate gatekeeper for making sure that things are consistent with the standards in the industry and allows for additional innovation as technology improves down the road. But for the providers to use this technology to issue prescriptions for glasses or contact lenses, it requires that they be a licensed provider in Rhode Island, that they're acting within their scope of practice, and they conform to the standard of care of in-person clinical settings. It requires that they actually read and interpret the data and consider factors beyond the technology's output. The language that was objected to is related to, not utilizing data as the sole issue. This language comes directly from the Connecticut law, where I can quote for you, where a provider may not use the data or information obtained for the administration of a test using a remote refractive device as the sole basis for issuing an initial prescription or renewing initial prescription. So the language in our bill is very extraordinarily similar, so it begs the question again, if they're allowed to operate in Connecticut and this is in place there, why are they really objecting to the proposals here? Furthermore, providers need to be able to verify who the patient is, that they're aged of 18 or more, that they can verify the prescription and the date of the last exam, that the provider create a medical record, and that they certify the diagnosis and disclose key provider information to the patient. What's objectionable about all those factors? Not different than what you interact with when you go see a person and get comprehensive eye coverage. The penalties that you may hear about are not established in law. They provide a guideline for the Department that the Department of Health establish these regulations with the proviso that nothing can exceed $10,000 per violation, and it's separate from any other provider penalties that they currently have authority over. So any penalties are still going to be set by those regulations, which are not in here, and we make sure that it's capped at a reasonable fee at that point. To date, 10 states have enacted version of consumer protection laws, 4 have adopted other variations, and 4 other states have acted through regulatory boards. Rhode Island is amongst 3 states that has an exemption to the telemedicine law that was passed in 2016, where it makes clear that these technologies are not telemedicine and thus not eligible for insurance reimbursement in Rhode Island. However, companies still market their online eye tests for private pay, stating, skip the line at your doctor's office, charging at times as much or more than a copay for a comprehensive eye exam when you're only getting 1/12 of what is provided of a comprehensive in-person eye exam. Leaving this issue unregulated poses risk to consumers and undermines comprehensive eye health care. You'll hear from some Rhode Island-based doctors tonight explain why this is important, evidenced by some of their patient stories they've experienced. You'll also, as we've already heard, hear from folks who prefer no regulation whatsoever. So with that, we know we can make this work, and it does work in other states. The objectors just don't want to be regulated. This is a failure for us to not protect patients by putting these simple guardrails up. So we urge your favorable consideration of this bill this evening. Lastly, we did receive a request from our colleague Leonard Lopes on behalf of FGX regarding an exemption for glasses known as readers. We're happy to work with him on this language because the intention is not to this bill to capture any of those items. So with that, I'm happy to answer any questions, and I thank you for all the time.
Thank you, Mr. Walsh. Are there any questions for Mr. Walsh from the committee? Okay, thank you for your testimony, Mr. Walsh. We're going to go ahead and move right along to our next witness.
Thank you.
Hello, Dr. Jablonski.
Hello.
This is Representative Casey, Chairman of the Health and Human Services Committee. You're here on House Bill 5612. If you would go ahead with your testimony, please.
Thank you. Thank you very much, Mr. Chairman and members of the committee. I'm Dr. Maria Jablonski, and I'm an optometrist, a primary care eye doctor. I've been in practice for almost 21 years now. My husband and I are Rhode Island born and bred, and we are raising our boys here. We live in Cranston, and that is also where my private practice is located. And I just want to thank you once again for the opportunity to speak to you today in support of the aptly named Consumer Protection and Eye Care Act. One of the best things about providing primary eye care is the relationship that I am able to have with my patients. It is not uncommon in my practice, and I'm sure that my colleagues would tell you the same thing, for me to take care of generations of the same family. I really get to know my patients. They are not merely a set of diagnostic measurements. And it is in the building of these relationships that trust develops and communication flourishes. So together, the doctor and patient can decide on the best options for treatment, including telehealth options. When you combine this with the way optometry has embraced technology and innovation, you have the best of both worlds, and you exceed the standard of care. So I want to make one thing very clear. This bill in no way prohibits or bans the use of technology. What we are trying to do here is illuminate the very real difference between telemedicine, which meets the same standard of care as an in-person examination, and telemarketing, which is what opponents of this bill are doing under the guise of telemedicine. It is clearly evidenced by the way these platforms market their technology. The importance and complexity of an eye exam is trivialized and made out to be an inconvenience. Technology serves us best as an enhancement to patient care, not as a replacement. If first-class eye care is the goal, and it should be the goal of each and every one of us, then these internet-based and remotely operated technologies must have guardrails in place. How can we, in good conscience, give limitless jurisdiction over Rhode Islanders' eye health to out-of-state companies that are not invested in our patients' well-being the way that we are? COVID-19 has forced us all to reimagine our businesses and our ways of doing things. Some changes have been very successful, and we have found even better or more efficient ways to remotely accomplish the same tasks. And in other ways, we understand more clearly than ever where the shortcomings are. I'd like to leave you with a patient encounter that I personally had, which perfectly illustrates where technology by itself falls short, sometimes dangerously so, and where an unsuspecting patient could literally be putting their health in jeopardy by taking an online vision screening, which they have been led to believe is a substitute for their doctor visit. Patients don't know what they don't know. I had a patient, a healthy 21-year-old man with no complaints or concerns, who came in for his annual eye exam and wanted to order more contact lenses. His vision had not changed in the past year. A preliminary gross examination was unremarkable. However, when I looked under his eyelids during slit lamp biomicroscopy, a component of every annual eye exam, I observed a subtle salmon patch that had not been there the year before. This is a growth indicative of lymphoma. A biopsy was ordered, which confirmed the diagnosis, and so through his routine eye exam, we were able to get him a timely referral and treatment that was necessary. And I am happy to report that this all happened over 5 years ago. Some of you on the committee may remember me and telling you this story before. And he is now cancer-free and doing great. But where would this young man be today if he had read an eye chart on his phone, taken a selfie of his eyes, which he had been led to believe was a telehealth visit, and gotten the rubber stamp of approval for his contact lens refill? Is that the type of care we want to promote to our neighbors, to our families, to ourselves? Opponents of this bill say claims like this are anecdotal and make up a very small percentage of cases. Anecdotal. Until it happens to you, or your spouse, or your child. And I've heard it argued, and you will too, that eye doctors are just using scare tactics in order to keep business in our offices, and that the actual incidence of serious problems that lead to blindness or worse is low. It will even be alleged that primary care providers are motivated by money and threatened by competition. Out-of-state retailers interested in boosting their own bottom line, levying false accusations at doctors who took an oath to do no harm. It's laughable, it's insulting, and it's downright dangerous. I went into this profession to take care of people and the precious gift of vision. I respectfully ask for your full support of the Consumer Protection and Eye Care Act, and I am happy to answer any questions that you may have. Thank you.
Thank you for your testimony, Dr. Jablonski. Are there any questions for the doctor from the committee? Okay, we're going to move on. Thank you, doctor.
Thank you very much for your time.
Hello, Dr. Zerbanopoulos.
Yes.
This is Representative Casey, Chairman of the Health and Human Services Committee. We are here on House Bill 5612. You have our attention. Please go ahead with your testimony.
Thank you, Chairman Casey and members of the committee. I'm Dr. Paul Zerbanopoulos, an optometrist practicing at the Rhode Island Eye Institute in South Kingston, here on behalf of the Rhode Island Optometric Association in support of this bill. I've been in practice here for 32 years. 16 states have taken action so far around the country in order to move what is a completely unregulated aspect of patient care to a responsible embracement of technology while still upholding the standard of care. This bill is really about how a valid prescription is issued. These companies have been able to fill a valid prescription in the past and can continue to do so moving forward. What they cannot do is change what constitutes a valid prescription without peer-reviewed evidence or FDA approval that their technology is valid. True telemedicine is defined by meeting the standard of care. This technology does not offer any of these basic tenets required to qualify as telemedicine. Rhode Islanders deserve to know that the health care they seek, whether from a local doctor or a doctor online, meets a minimum standard care. This bill seeks to achieve that. Work and life in general become much more difficult without vision, and your two eyes cannot be replaced. None of these companies' technologies will screen for the top 3 causes of vision loss: glaucoma, macular degeneration, and diabetic eye disease. Yet this technology has historically been promoted to consumers as an opportunity to, quote, skip the eye doctor, close quote. There is no cost savings as they would lead you to believe. Their fee is for 1/12 of a comprehensive eye exam, the refractive component only. Often the fee for their limited, unproven technology will be the same copay as a comprehensive exam. Why pay for 1/12 of an exam when you can have a comprehensive eye exam for the same price and be reassured your eyes are free from sight-threatening diseases? I would like to emphasize that the Rhode Island Department of Health position statement on telemedicine states that not only is filling a prescription based solely on a patient questionnaire not telemedicine, it is unprofessional conduct. And that's really what we're talking about here with most of these companies. They're just rubber stamping an existing prescription. In summary, we're seeking guidelines for the responsible deployment of new technology that meets the current standard of care. It does not put unsuspecting patients and Rhode Islanders at unnecessary risk of irreversible vision loss. I'm happy to answer any questions.
Thank you for your testimony, Doctor. Are there any questions for Dr. Zerbanopoulos? Okay, sir, we're going to move on to our next witness. Thank you very much.
Thank you.
Dr. Montequila.
Yes.
Hello, this is Representative Casey, Chairman of the Health and Human Services Committee. You're here with us on House Bill 5612. If you would go ahead and give your testimony.
Thank you. Thank you, Mr. Chairman and members of the committee, for allowing me time to speak in favor of this ever more important healthcare consumer protection legislation. I am Stephen Montequila. I'm a board-certified optometrist practicing in Warwick. I'm a fellow of the American Academy of Optometry. I chair the Rhode Island Optometric Association's Legislative Committee, and I'm a member of the American Optometric Association's Federal Relations Committee. In addition to clinical practice, I serve as principal investigator on many drug and medical device clinical trials, including in the areas of dry eye medications and contact lenses. And as you've heard, and as we all know, we certainly are faced with unprecedented times. We've seen alternate models of healthcare delivery proliferate. Not all have been to benefit our patients. I want there to be no mistake. We are fully in support of legitimate telemedicine. Those methods should deliver care that meets or exceeds the standard of care. In many cases, these technologies do not. And as Mr. Walsh explained, the whole goal of this bill is to direct care towards the standard of care. we've seen retailers who you hear speaking tonight use these kind of pseudo-telemedicine technologies to sell more glasses and contact lenses. We actually saw one of them advertising through the pandemic, while your doctor is closed, use our technology to renew your prescription, while your doctor is unable to be at your office. And the fact was, most doctors were in their office to see emergencies and follow-up care that was necessary during the pandemic. They were there as frontline workers while these companies sat, in their little offices trying to tell patients, don't go to your doctor, come to us and renew your prescription. We know that currently these online technologies do not rise to the level that would be necessary to truly do the examination that would be needed to fit a medical device such as a contact lens or to diagnose, for example, dry eye disease. However, these companies are online providing these services. They're providing prescriptions for medications without really examining a patient. They're providing contact lens prescriptions, eyeglass prescriptions. And again, should their technology reach the level where it's appropriate for use, this bill does nothing to prohibit that. This bill is, in fact, a collaborative effort between optometrists and ophthalmologists. I've heard them state that ophthalmologists are not here to testify. Well, the fact is they've agreed with us, which is why we are here providing this testimony for you. And our goal, as Mr. Walsh said, is to place the necessary guardrails around the use of this or any other technology used to treat, diagnose and treat diseases or conditions of the eye. Again, as long as those technologies meet the standard of care. I want to clarify a couple of things that I heard earlier from, I believe it was the gentleman from Warby Parker who incorrectly stated that 50% of revenue in practices is from the sale of glasses. I just looked that up now, and the most recent statistic that you can find from a review called Optometric Management says that 19%, in fact, of revenue is generated from eyeglasses in average practices. More importantly, I think one of the other statements he made reflects the exact reason why we're here. He claimed that his company is unable in some way to determine the date of a patient's most recent exam. The fact that they can't reach out to a patient's previous provider or obtain a copy of their last valid prescription to understand when their last examination was speaks to the lack of ability they have to provide healthcare services. I mean, this is something we do every day in our office. Patients come in, we need to understand their history. They should need to understand their history as well. So again, why are the guardrails necessary? I think they explain it to us why they're necessary. I want to just take one moment, if I may, just to reflect on a patient who I saw just this past week, who came in after having done a telehealth type visit with an app where she was quote unquote examined by some sort of FaceTime-like app. She thought she had pink eye. The doctor who quote unquote examined her with this FaceTime app agreed, you must have pink eye, so gave her a prescription for a medication. When she didn't get better after a few days, she went to a walk-in. The walk-in immediately realized they didn't have the technology to examine her, and they sent her to my office. She had an ulceration on the surface of the eye that we were able to diagnose with the proper technology. We were able to begin treatment, and she's doing well, hopefully avoiding permanent vision loss. The unfortunate thing here is that she went through all of these steps before because there was no guardrail. There was nothing to guide that first provider to say, geez, I don't have the technology to be able to properly examine you. So again, that really is the heart of what we're trying to accomplish here. So I question when you hear these companies say that, we won't work with them and so forth. As Mr. Walsh illuminated, the language we're using is language these companies have endorsed in other states. So the question is, what is there to work with? They've already endorsed the language. We're just repackaging it here in our state of Rhode Island. So I think, again, you have to question, what are these companies really up to? Are they acts of ignorance? Are they acts of desperation? They try to hold on to any of these lies they keep telling themselves and us. They fight regulation, but we have to ask why. Thank you for your time and attention. I'll be happy to answer any questions that you or the committee may have.
Thank you, Doctor. Are there any questions for this witness? Okay, we will go on to the next caller. Thank you. Hello, Christopher.
Hi there.
Hi, this is Vice Chair Donovan. You are testifying on Bill 5612. You can proceed.
Thank you very much, Madam Vice Chair. Thank you for the opportunity to testify. I know you've heard a lot of testimony today, so I will be brief. My name is Chris Gilrain. I am with TechNet. We are a national bipartisan network of companies with concentrations throughout the innovation ecosystem, including e-commerce, IT, clean energy, autonomous vehicles, and telehealth. HB 5612 would severely limit access to vision services that many Rhode Islanders have come to rely on over the past 4 years, and particularly over the last 12 months. These platforms offer patients an option for convenient, accessible prescription renewals at an affordable price point. HB 5612 would restrict these services. Just over the border in Massachusetts, Attorney General Maura Healey recently released a report regarding persistent racial disparities in healthcare that have been made all the more obvious during the COVID-19 pandemic. That report included, in part, recommendations promoting telehealth as a key factor in enhancing access and racial equity in the provision of healthcare services. The report went on to recommend legislation that would increase access to these services. HB 5612 would do the opposite. Telemedicine has proven to be a crucial component of a more inclusive healthcare system, and the vision care services being discussed here today are part of that. They've been operating safely and successfully here in Rhode Island for 4 years, and we ask the committee not advance this bill so that they may continue to do so. Thank you again for your time and consideration. I have provided written testimony, which links to that reference report.
Thank you, Christopher. Are there any questions for this witness? Okay, we will move on to the next caller. Thank you.
Thank you.
Hello, Mr. Lopes. You're testifying on Bill 5612. You may proceed.
Yes, thank you, Madam Chairwoman and members of the committee. Leonard Lopes on behalf of FGX International, a Rhode Island-based company, which is a company that is the world's leading designer and marketer of non-prescription reading glasses, optical frames, and sunglasses, with a portfolio of some of the world's most recognizable brands, including Foster Grants, Magnavision Gargoyles, and Solar Shield. I want to also, at this time, thank Representative O'Brien for listening to my concerns, as well as Mr. Walsh, who I had the pleasure of speaking to over the weekend. And with that, I just want to say that I am submitting to those gentlemen an amendment that would respectfully clarify the language and exclude the non-prescription reading glasses that my client sells, because it's my understanding that the intent of the bill was never to impact those types of products. So with that, Madam Chairwoman, I conclude my testimony.
Thank you, Mr. Lopes. Are there any questions for this witness? Okay, we'll go on to the next caller.
Thank you. Mr. Goldberg?
Hello, Mr. Goldberg. This is Vice Chair Donovan.
Good afternoon.
Hello.
Hello, how are you?
Good, thank you.
Are you ready?
Yes, we are. You can testify on the bill.
Okay, thank you, Madam Chairwoman and members of the committee. I assume I'm near the tail end of the evening, so I'll try and be brief. What this bill does is it takes away an existing situation. It doesn't add to something, but it takes away the practice of 15,000 Rhode Islanders who have been using this process successfully, and as you heard earlier tonight, with no complaints, no lawsuits, no problems whatsoever, and takes it away and forecloses that avenue of purchase for contact lenses. We heard a lot of talk about standard of care. What this does is reduces the period between comprehensive visits from what the American Academy of Ophthalmology recommends to the local optometrists and what they recommend. Well, who's the beneficiary? Guess what? But we've also heard talk about this is no replacement for a comprehensive eye exam. And quite frankly, we agree with that. It's not, and it's not intended to be. The question is, how frequently do you need a comprehensive eye exam? Now, we heard testimony about the doctor-patient relationship and how much confidence there is in it and communication and whatnot. Well, if these optometrists want to see a patient sooner than the American Academy of Ophthalmology recommends, all they have to do is look across the table and tell them when to come back. We are not seeking to prevent any comprehensive exams. If a patient wants to, fine. If they have a symptom, if they have an itch, if they have pink eye, go to the optometrist. We're all for that. That's not what this is about. I heard the term guardrails, and that's a new spin on things, when you put an utter and complete stop to a practice. It's curious to me they want to stop telemedicine and distance treatment by the middle of a pandemic. Now, every single prescription for continuation under these platforms is reviewed by a Rhode Island ophthalmologist. This is not haphazard. This is, by the way, the third or fourth year in a row we've been through the sky is falling if you don't pass this bill. Well, guess what? Here we go again. The sky's still falling. I heard the acerbic comments of lies and all of that, and it's just not called for in a hearing like this. But we object to this legislation. It does foreclose future advances in telemedicine. It forecloses the current technology, and I neglected to say at the outset whether I'm for or against. For those of you who are getting ready to go home, I'm against this legislation, and I'm testifying this afternoon or this evening on behalf of 1-800-CONTACT and CVS Health, who also opposes this legislation. And that's what I have given the hour.
Thank you, Mr. Goldberg. We appreciate your testimony. Are there any questions from the committee for Mr. Goldberg? Representative Fogerty, are you trying to get my attention? Okay. Thank you very much. Thank you, Mr. Goldberg, for your testimony. That will conclude the testimony on House Bill 5612, and that concludes our calendar for the evening. If there are any questions or comments from the committee at this time, I will entertain those. Hearing none, I will accept a motion to adjourn from Representative Potter, seconded by Representative Donovan. All in favor? Thank you very much. This closes the hearing for Health and Human Services on March 22nd, 2021. Have a good evening.